At a large meeting, it's always fun to ask people what they thought were the highlights. So we did that throughout this meeting, and what they came up with were a variety of different studies, and we thought we'd pass along to you here at ASH Clinical News some of what people here attending this meeting thought were the hematologic highlights.
So my focus has been on multiple myeloma, and there really was an amazing amount of material. First of all, some of the newly developed drugs, antibodies, daratumumab, anti-CD38, shows high-level activity in very heavily pretreated patients with multiple myeloma. So a truly new class of drugs when chemotherapy fails. Also, elotuzumab, the anti-SLAM7 drug, also showed activity in combination with lenalidomide and dexamethasone, producing an improved progression-free survival compared to the regimen without the antibody. We saw new uses for the histone deacetylase inhibitor panabinostat. It has shown in use with bortezomib improved progression-free survival. Now it's been analyzed in patients who are dual refractory to proteasome inhibitors and immunomodulatory drugs, and shows both improved progression-free survival and a higher proportion of complete and near complete responses, deeper responses that translate to even longer progression-free survival. Moreover, panabinostat has now been combined with carfilzomib and lenalidomide, and the toxicity that previously was reported, fatigue and diarrhea, was seen in only a very small percentage, so a much better tolerated combination. There was a phase 3 trial of carfilzomib dexamethasone to bortezomib dexamethasone, showing an improved clinical outcome with the carfilzomib regimen and much lower toxicity, particularly neurotoxicity. A new regimen for induction prior to transplant included carfilzomib, lenalidomide, dexamethasone, followed by an auto transplant, followed by consolidation therapy. Response rates 100%, complete response rates 100%, but more importantly, minimal residual disease negativity, which is our measure to see who might be cured, 87%. So that was remarkable. There was one other trial in transplant-eligible patients that looked at bortezomib consolidation versus no consolidation, strongly favoring the use of bortezomib consolidation after transplantation.
Well, actually, I think there were a number of actually very interesting randomized clinical trials that were presented at this ASCO meeting. One clinical trial in chronic lymphocytic leukemia sought whether incorporating the novel BTK inhibitor ibrutinib for patients with relapsed CLL would optimize the response rate to traditional chemoimmunotherapy. Ibrutinib, as we know, is a highly active drug, FDA approved for relapsed CLL, highly active even in high-risk patients with 17p deletions. What this clinical trial, called the Helios trial, did is compare bendamustine rituximab to bendamustine rituximab ibrutinib in patients with relapsed CLL. What they found was an increased complete remission rate and a remarkably improved progression-free survival, favoring the incorporation of ibrutinib compared to bendamustine rituximab alone. And in fact, the hazard ratio was 20%, suggesting an 80% improvement in risk of progression, favoring combination chemotherapy with ibrutinib. Now that said, there's a big unanswered question in that trial, which is we use ibrutinib as a single agent in the relapse setting, and it works great. And so the question is what would ibrutinib alone have done in this randomized trial? And how much is the bendamustine rituximab actually adding? Because it certainly adds toxicity. And that question can't be answered by this clinical trial. It shows we can definitely safely combine BR with ibrutinib. It shows it is effective. The complete remission rate was not dramatically high. So my real question is, would we see a very similar magnitude of benefit by giving ibrutinib alone? The CLGB, or Alliance Cooperative Group, is right now doing a very important upfront 3-arm randomized trial, this time in previously untreated disease, giving BR versus ibrutinib plus rituximab, asking that very question of how much does ibrutinib add to BR, or alternatively, how much does BR or rituximab alone add to a drug as highly active as ibrutinib monotherapy? A lot of more interesting data coming forward on how we combine these novel targeted agents in the setting of CLL.
Now, there were some interesting hematologic papers presented here. In fact, when you first came up and we started talking, you mentioned the one by Mark Lillis, who we just chatted with moments ago. What are you finding interesting here at the meeting?
Well, we're always interested in what Mark says because FLT3 mutations are a significant issue and a significant target in AML. It doesn't prevent them getting remission, but it increases the risk of relapse. And even if you transplant them, they don't do brilliantly. And the trick is to get them to transplant before they relapse. So for a long time, there have been a number of FLT3 inhibitors tested. Some have been effective in that they produce a transient response, mostly clearing the peripheral blood, but often not the bone marrow. And some of the better ones clear the bone marrow as well. So, Mark Levis is the world leader in this development, and we all get taught by him what to do. So the drug that he presented this time seems to have the interesting benefit of durability of response. There may be a suspicion about count recovery and all this sort of thing, but it certainly looks another promising agent. Having said that, we've seen other promising agents come and go in this situation. So that was encouraging. As far as myeloid disease is concerned, and I should declare an interest that I'm employed by the company that has pacritinib, who have been not a trial I had anything to do with, but had been running the trial and looking at myelofibrosis, for which there is an approved treatment, but the approved treatment of ruxolitinib is not optimal for patients who have a low platelet count, whereas the pacritinib appears to work in that population as well, probably because it's limited to JAK2 as targeting, so it has no effect on platelet production, whereas the JAK1 inhibition component probably has. So, that probably helps patients, we think, and there is an unmet need, so we'll see how it goes.
Well, I think there were some very interesting clinical abstracts presented at the leukemia session yesterday of some novel agents that actually, and I hate using the word promise because it seems a little false almost often, but there were some very interesting and hopeful abstracts of early stage trials for both AML. I thought was a very interesting and important abstract on a novel FLT3 inhibitor with a high response rate, and also another very interesting to me abstract for patients with myelofibrosis of a novel JAK2 inhibitor, which for the first time that I've seen actually seemed to improve not just symptomatic control of myeloproliferative disease, but also actually had an impact on the bone marrow environment by improving anemia.
It's Dr. Mesa at his group.
Yes, and I thought that was also very interesting. So those were two of the abstracts, and then of course the long-term follow-up on the CAR T cell, longer-term follow-up on the CAR T cell therapy for acute lymphoblastic leukemia, which I think is fascinating and extremely exciting for our patients who have these very difficult diseases, and so that was good to see the sort of continued support for very, very high response rates with this technology.
I think another novel targeted therapy that was explored at this meeting in a randomized trial was the next generation anti-CD20 monoclonal antibody obinutuzumab. Now, obinutuzumab is a type 2 anti-CD20 monoclonal antibody, which clearly has superior activity to rituximab in chronic lymphocytic leukemia, for which it is FDA approved for the initial treatment in combination with chlorambucil in older patients with multiple medical comorbidities. An outstanding question, however, is whether it adds to the efficacy in the treatment of patients with traditional B-cell non-Hodgkin lymphomas, where rituximab continues to be a standard of care. Presented at this ASCO meeting was a randomized trial called the Catalan study. What the Catalan study did is it sought to target a high-risk subset of patients with relapsed indolent lymphomas. And they defined this as patients with what we call rituximab refractory disease. Patients with rituximab refractory disease have had their disease either progress on rituximab therapy or within 6 months of receiving rituximab therapy. We know these patients have a high-risk disease and a poor overall outcome. Usually these patients are chemotherapy resistant as well, which is true in approximately 80% of patients in the Catalan study. Now in the Catalan study, the standard arm was bendamustine alone, without rituximab because, of course, these patients were defined as rituximab refractory. The comparator arm, however, was bendamustine plus the newer anti-CD20 molecule, obinutuzumab. What this clinical trial showed, comparing bendamustine to bendamustine plus obinutuzumab, were similar overall response rates. But actually, very interestingly, the progression-free survival was dramatically improved in patients who received the obinutuzumab in combination with the bendamustine. Now, in that arm, patients received bendamustine plus obinutuzumab, followed by obinutuzumab maintenance. So they received some ongoing anti-CD20 therapy. However, in that population, compared to bendamustine alone, the progression-free survival was approximately doubled to close to 30 months compared to about 15 months. So really remarkably, and I would say clinically relevant improvement in progression-free survival. At limited follow-up, there's no difference in overall survival, but time is short, and that really is quite an exciting improvement. It amounted to a hazard ratio of 0.55, meaning nearly 50% improvement in the risk of progression.